Hi, everybody. I'm Michael Carrese, welcoming you to Raise the Line from Elsevier, an ongoing exploration about how to improve health and healthcare. 1 in 5 adults in the United States experiences mental illness each year, yet more than half never receive treatment. As we mark Mental Health Awareness Month this May, that gap is a reminder of how much work remains to be done. Our guest today is Dr. Stephen Strakowski, professor and vice chair for research in psychiatry at Indiana University School of Medicine. An internationally recognized expert in bipolar disorder and other mood conditions, Dr. Strakowski has spent his career studying the treatment, outcomes, and neurobiology of these disorders, while also leading efforts to improve racial equity in how psychiatric care is delivered and studied. Among other consequential roles, he serves as editor-in-chief for the Journal of Mood and Anxiety Disorders, which is published by Elsevier, and creates national impact through his work at the American Brain Coalition and the National Network of Depression Centers. Today, we're going to explore what decades of research have taught us about mood disorders, where the field's heading, and what it will take to build a more equitable mental health system. And thank you so much for joining us today, Dr. Strakowski.
Nice to be here.
So we'd like to start with learning more about you and what first drew you to psychiatry, and then specifically what sparked your interest in the study of bipolar disorder and mood conditions.
Could be a long story, but I'll try to keep it short. I actually went to college and ended up as an engineer, and then ended up at the time developing my own biomedical engineering degree at Notre Dame before it existed.
Wow.
And so that's how old I am. So that's part of the framework here. And went to Vanderbilt then for medical school with the intention of doing a neurosurgery career because of some work I'd done in college with people with paraplegia. And so I did research in spinal cord regeneration while in medical school. But in the process of doing that, I ended up thinking about changing what I wanted to do. And again, back in the old days, it was very different. On my psychiatry rotation, on the second day we were on it, my resident had her first psychotic episode.
Oh, my goodness.
Yes. And so was kind of whisked away by the attendings, and we didn't see her again. Again, back in those days, the med students had basically ran the unit because the residents ran the units. Very different than today. And I'd never really had any exposure to psychiatry growing up in a little town. And so it was really interesting. And the parts of the brain I ultimately was interested in are the very human parts of the brain, which is what psychiatrists deal with, right? And so I think that experience was so positive that I completely changed my mind on what I wanted to do. And I did pretty well in med school. And at the time, those of us who did well were encouraged to do competitive things like orthopedics. I think in my class of 90-something, there were 10 orthopedic surgeons now.
Right.
And so when I announced I was going to go into psychiatry, there was a robust effort to get me to change my mind during my fourth year. Yeah, it was very different world back then. But I stuck with it, and I have to say, 30-some years later, that I've not once regretted it. The bipolar interest really came out of when I was in residency at McLean Hospital in Boston. We had started doing some first episode psychosis work, and because of the nature of the population McLean treated at that time, it ended up being predominantly people with mania. It's just a fascinating condition. It's so strongly hereditary, unlike really anything else in psychiatry. And back in those days, we hospitalized people till they recovered. So we could actually, as trainees, watch them go from being very, very ill to completely, typical. And we'd had these Harvard and MIT students would come in very sick and then would go back to school. And again, current training in the U.S. doesn't allow that, but at the time it did. And for me, it was just a fascinating experience to watch this clear brain disease go through its cycles. And so I've been doing that kind of work ever since. 15 years later, I got a call from relatives and learned that it was in my family.
Oh, my goodness.
But up till then, I'd never known. And so it shows a couple of problems highlighted here, right? The stigma trying to drive people out of it in medical school, and the stigma that even within a family, even when there's a psychiatrist in the family, no one talks about mental illness. And so those things have kind of stuck with me also as part of what's driven my career choices.
Yeah. No, that's fascinating. And, for listeners who are maybe not deeply familiar with it, can you give us the overview of bipolar disorder and the difference between 1 and 2?
Sure. So bipolar disorder in both cases is defined by the occurrence of either mania or hypomania. Bipolar 1 is defined by the occurrence of mania, which is a condition with reward hypersensitivity, high activation, and accompanying mood extremes, euphoria being the kind of classic one, but it really can be almost anything, and lability is typical. We can talk about why I think that is if you want later. Bipolar 2 has to have the occurrence of hypomania, which are all the same symptoms of mania, but they're less impairing, and then has to have episodes of depression also. And so that's how they're at least differentiated in the DSM. So depression is not required in bipolar 1 disorder, and in fact does not occur in maybe 10 to 15% of cases. But by definition, it has to occur in bipolar 2. Depression tends to be the dominant mood state for both.
And what do we understand about the roots and what drives this?
Well, ultimately, these look like they're genetic illnesses that are probably, in my opinion, require the genetic substrate to put you at risk. And then whether you're going to develop the illness results from a combination of that genetic substrate and probably environmental events like certain types of stressors or childhood trauma, bad luck. I mean, there's, who knows, and drinking too much, just whatever. And so ultimately what we think it is it's a developmental problem of the reward system. And people with bipolar disorder, they're hypersensitized to reward, even when they're not in mood states. And they end up in this kind of vicious cycle where the rewards drive more reward seeking in ways different than typical people, where we often pause after achieving something before we keep going. The people with bipolar disorder's brains are designed to not do that. And so that ends up ultimately leading to this state of excessive, not sleeping and then excessive energy, coupled with other underlying brain developmental differences from other people. The way we think of it then is the mood states are just the brain signaling you to keep doing what you're doing, right? So if you're seeking reward, euphoria is the signal your brain's sending you to keep doing what you're doing. Irritability and frustration is that you've been thwarted, and so it's telling you to try something else. So I tend to think of bipolar disorder as a reward processing illness first, that then is exemplified through behavior and mood.
It's got a reputation for being difficult to diagnose. Do you agree with that, and why do you think that is?
I do. Bipolar 2 is hard because people rarely seek treatment for hypomania because it's by definition not impairing. And so no one's incentivized to get help when they don't feel impaired, right? And so that requires often a retrospective assessment of something that people tend not to feel is impairing. And it's hard to get that information. And so it's not unusual for someone to be diagnosed with just depression, and then finally the hypomania reveals itself in the office where you can actually see it, and that helps make the diagnosis. Bipolar 1 disorder gets complicated by the psychosis, which distracts people to schizophrenia and other conditions that often doesn't always emerge immediately as mania. It emerges in the teen years as something else, depression or some lability or something. And so it can often cause people to go a long time before they're recognized or they're misdiagnosed. In the United States, we've shown that if you're Black American, you have a high rate of being misdiagnosed with schizophrenia when you're actually manic, more so than even in a similar white population. And so a number of factors contribute to the point that the diagnosis is often delayed as long as 7 to 10 years. And I think it's particularly complicated in the bipolar 2 group.
No, that's a long gap. You've mentioned lability a couple of times. Could you fill us in on that?
What I mean by that is that your mood goes from kind of extreme highs, extreme lows, irritability, and it moves relatively rapidly among them. And that's been well described historically as a part and parcel of mania. Again, the historical thinking was just the euphoric side, but that is not necessarily present in all patients, and maybe not even being a majority. And there's an old book by Kay Jamison and Fred Goodwin called Manic Depressive Illness, great big tome, where they did a very nice job of summarizing literature and showing that. It gets lost, I think, sometimes in our criteria sets now.
You did mention the racial equity issues, or this phenomenon of Black patients presenting with the same symptoms will be diagnosed with schizophrenia instead of bipolar. So let's get into that some. What does the evidence tell us about why that happens? And, what are some of the remedies?
Yeah, so in our work, I think what we've found is that for probably cultural and structural and racist reasons even, mood symptoms tend to be minimized in Black Americans, and psychotic symptoms overemphasized, even if they're the same in a white and Black patient. And there's, some history, and unfortunately, all the way back to slavery, where it's purported that Black people didn't get depressed. Again, that was a slave owner's way of kind of justifying clearly immoral behavior, right? That perpetuated itself into even now the modern times. And so it just tends to be under-recognized. And also talking about being depressed is a vulnerable thing to, it opens you up, makes you vulnerable. And if you're a Black patient distrustful of a white institution, you may be less likely to talk about that. Whereas the psychotic symptoms become so dramatic that they can be hard to miss. And so we think it's a combination of kind of historical racism coupled with perhaps race differences of how we talk about illness in certain settings. We found that when you do a careful, structured diagnostic interview, it doesn't eliminate the whole problem, but it dramatically decreases it. And we think what it does is it kind of forces the clinician to pause just enough to say, wait a minute, I just said that they were, not sleeping, highly energetic, euphoric, and they're also psychotic, but I've been underemphasizing the first three, and that's what I need to emphasize. We've tried to think about, is there a way to use the, modern technology, AI, other things to remind clinicians, hey, you just documented these things, make sure you consider them when you make the diagnosis. And that could be actually a very good use of something like AI and diagnostic assistance.
Are you seeing any trend either to the positive or the negative in terms of how often this is happening?
No, it doesn't look like it's changed much over the last 20 years. There was a belief for a while that inequity in healthcare coverage was part of the problem, and so that when Obamacare hit, that would even out things, and it didn't fix it. It's more ingrained than that, I think, in our culture. And so the good news is the vast majority of clinicians want to take the best care of the person in front of them possible, and they don't want to be biased by unconscious race bias that everyone has and that they're not paying attention to. And so we think that with just some assists, we could dramatically improve the situation, but that has not yet happened yet. My friend and I are working on a book about this now, and very little has changed, unfortunately, in the 30 years we've been working on this.
Yeah. So let's talk about treatments. What's the state of the art for treatments, and how effective are they?
I think there's a misperception that psychiatric treatments aren't effective, and that's just not true. And there have been studies in the past that have compared us to other branches of medicine, and we have similar kinds of response rates. So every branch of medicine has people who don't get better, and they have people who do get better, right? So generally speaking, we've certainly got evidence-based treatments in bipolar disorder that decrease the number of episodes and improve long-term outcomes. There's no doubt that's true. With lithium being, the gold standard that was discovered in 1946 and continues to be, in my opinion, a first-line choice, and maybe the first-line choice, certainly for long-term care. Now, are they perfect? Absolutely not. They have lots of side effects, and people can't always tolerate them, and we don't fully understand how they work, and all of those things limit our ability to provide even better care. And so there's no doubt that we need to continue to work to understand the condition in order to come up with better options. It often gets talked about like it's a psychiatry problem, but that's not really unique to psychiatry. That's true with virtually every branch of medicine. And only a few have managed to now get to genetic markers and all kinds of things that, really personalized care. We just aren't there yet, but I do believe we'll get there.
So as the editor-in-chief of the Journal of Mood and Anxiety Disorders, you're in a pretty good spot to see the research, obviously, that's going on and what's coming down the pike. Is there anything happening that you're very encouraged by? Where is this going?
Yeah, well, I think, there have been a couple of things for me in my career. The first was when there was some discoveries of anticonvulsants being effective, which broadened our capability from lithium alone. And then the second and third generation antipsychotics that really aren't just antipsychotics, but have lots of other purposes, have really expanded our menu of choices. For a little while, the CNS pipeline dried up a bit in pharma, but it seems to have expanded again, and there's been some new novel mechanisms that are being investigated. There's certainly interest in the neuromodulatory therapies, like TMS, which hasn't yet, for bipolar disorder, been well described how best to do it, but is very promising. And so for me, I think it's all really encouraging. We understand better at least where in the brain the problem is, what systems are involved, which allows us now to develop biological targets to look at how treatment affects these systems and ultimately understand the underlying mechanisms better. And as genetic research continues to advance, who knows, eventually there will be gene therapies to treat this very hereditary and genetic illness. So I'm encouraged. But it's slow, and it turns out that the brain is complicated. And I always like to say, to colleagues and trainees, that when we choose to do this kind of work, we're studying probably the single most complicated thing in the entire universe, barring some alien somewhere that has a more complex brain than us. And so it's no wonder that it moves slowly. And there's just so much inherent complexity to understand how the brain works that it just moves slowly. But despite that, I think we've made some nice progress. Not as fast as we've hoped, and certainly not as fast as we often predicted. But nonetheless, I feel like we've made advances over the years.
Great. So Elsevier is an education company. We always like to find knowledge gaps to fill, and we like asking guests to give us some direction in that regard. So is there a topic, it could be in your field or outside of it, where you would say, people don't understand this or there's myths about it, and it would be great if Elsevier made a video about it? What would that be?
Yeah, I mean, there unfortunately continues to be significant stigma around mental illness and the treatment of it. We just heard that recently in our own government announcing they want to eliminate antidepressants. Well, okay, but yes, there are other treatments, but that doesn't mean that we should eliminate things that have been shown to be effective. And those kind of comments are generally based in stigma, right? And no matter how much progress we make in understanding the brain, that continues to just persist. And it's not unique to the United States. It's true worldwide. So I think there's continued improvement, and we could really use educational campaigns to continue to destigmatize. At this point, we largely rely, frankly, on the celebrity media world that helps destigmatize when celebrities come out and acknowledge their illness. And I appreciate that they do that, and often they're kind of outed against their will. But I appreciate that they do that, but that's really not an organized campaign.
Right.
And so... And there have been attempts at the government level, and the Surgeon Generals have tried to, a couple of them have launched some reports, but we need to develop some consistency there. The number one thing, I'm a brain imager and a neuroscientist, but our treatments are reasonably good, as we talked about. They're not, not perfect, but they're reasonably good. The big problem we have in the United States and then generally worldwide is people just can't get access to them. And so the numbers are more than half of people who would benefit from treatment don't get it. The fastest way to make an advance in the mental health of the United States or any country is to figure out how do we get people so they can get into and afford care. And those barriers continue to be probably the most difficult limitation and improvements. I think about that when I'm trying to cure bipolar disorder, I'm either, depending on your religious beliefs, I'm either trying to figure out a problem God caused or a problem 10 million years of evolution caused. When I'm trying to improve access, I'm just trying to get arbitrary policies that human beings created fixed. One would imagine that should be more fixable. It turns out maybe not, but one would imagine that's probably true. And so I think if we could do anything to continue to push there, and if you all could educate on why that's important, that would be great.
Is it just a workforce issue, not enough people going into psychiatry, or what are some of the other key factors here?
Yeah, it's partly that. maybe less at the psychiatrist level, because there are more and more people going into it, which is good. That's been a really interesting change for me to watch psychiatry residencies become competitive, because that was not true for most of my career. But it's paying all the other individuals, licensed social workers, counselors, psychologists. The whole workforce needs to be engaged, because we will never mint enough psychiatrists, enough physicians to do all the work that's required given the demand. But we underpay all of the other folks so badly, and the reimbursement is so poor, given the amount of education, training, and time it takes to do this work, that that's the single biggest barrier. As someone who's worked on this, worked on in Texas quite a bit, there's, again, a false belief in government and in society that if we try to treat it, we'll be bankrupt, so we just have to ignore it. But when you ignore it, it ends up costing you somewhere, and it's usually in the most expensive places like hospitals, emergency rooms, jails and prisons, backseat of the sheriff's car, and then suffering and suicides. And so we're spending the money no matter what. And we just need to figure out now, how do we, instead of randomly and arbitrarily spending money on mental health, we start spending it rationally and in an organized, beneficial way. And I think that's the challenge. And I also think would be the fastest way to improve mental health in the United States and worldwide.
Well, you've convinced me, if that counts for anything. As we wrap up here, we have a lot of students and early career professionals in our audience, and we like our guests to give them their go-to advice for starting a career in healthcare and dealing with all the challenges that come with that.
Well, the first thing I like to tell people, yes, there are challenges, but I have to say, for me, and I mentioned already, I've never once regretted becoming a psychiatrist. If you pause from the day-to-day grind of work and think for a minute, we live a very privileged life. We are sought out by people usually at the worst times of their lives, and they seek us out to help them through it. And that's an incredible honor. And so first of all, as you do this work, don't forget that. And particularly, when you're an intern and resident, I get it. It's overwhelming and tiring. But don't forget that. And then second, the reward for that is that people do get better. And you can really dramatically improve someone's life. And every time we do that, every time we improve the lives of people around us, we improve the planet. I think that's the part to keep in mind. Then the second part, find the branch of medicine, the type of medicine that you find the most interesting, and then do that. Don't let people try to talk you out of it. And I think you'll find that it becomes a really rewarding career.
Well, that's wonderful and inspirational advice to end our conversation with. I want to thank you so much for your time today and wish you all the best in your work.
It is my pleasure, and I appreciate working with you all on our journal. So thank you.
I'm Michael Carrese. Thanks for checking out today's show. And remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.